Hello and welcome to the MedEdit podcast, your ultimate resource for evidence-based medical education.
Today, listeners, we are talking all things high blood pressure or hypertension in honor of upcoming High Blood Pressure Education Month. We will tell you what it is, the symptoms, risk factors, possible complications, and most common treatment options.
Then we'll pivot to give you factual information regarding the current measles outbreak in Texas and what happens to be where we are living at the epicenter.
Let's get started. We are your hosts, Dr. Cari Sorrell
and Dr. Jessica Gray.
Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast.
All right, Jess, high blood pressure or hypertension may not be the sexiest medical topic that we've ever discussed, if there is such a thing, but it's a really important one. 47 to almost half of adults had hypertension as of 2023, and it gets as high as 70% in adults who are older than 60. I know this is something you manage all day, every day.
Yes, this is my bread and butter. This is what I see in clinic, like you said, all day, every day. And you're right. What's really scary and why it's often referred to as the silent killer is that only about 60% of adults with hypertension were aware of their condition. Also, only about 20% have what we consider controlled hypertension, meaning that they actually have it, they're on medication to control it, they're in the target range. And like you said, I see this all day, every day.
Probably almost every patient.
Almost, really, truly.
All right, so tell us, what is hypertension or high blood pressure? How do we define it?
So let's just start at the basics. Like you said, hypertension or high blood pressure is a chronic medical condition where the force of blood against the walls of the arteries is consistently too high. It can lead to serious health problems, including heart disease, stroke, and kidney failure. Your blood pressure is measured in millimeters of mercury and consists of two numbers. You've got the systolic pressure, which is considered that top number. And this is when the pressure of the heart beats. You feel that big beat there, that first one, of that lub dub. The diastolic pressure, that's the bottom number. That's more the dub. That's the pressure when the heart is at rest between the beats.
What is considered a normal blood pressure and what would be considered an abnormal blood pressure?
So I hear this all the time because patients will come in and we see their blood pressures may be elevated in that visit. And I say, do you check your blood pressure at all at home? And they say, yeah, sure, it's always normal. So I've learned after, over a decade of doing this that we really need to put some definitions on what normal is. And because what normal is for a patient isn't normal what it is for a physician. And not to mention some of our colleagues that, let's say, are a little more mature in their, years of experience, they may have noticed that the actual definitions for normal blood pressure has changed over the last several years as well. Yeah. So what we consider to be normal now is a more aggressive stance for blood pressure. We would say that normal would be below the number 120 for that top number and below the number 80 for the bottom number. Everybody always thinks that 120 over 80 is, quote, normal. It's actually not. Below 120 is normal and below 80 is normal. Then you hit into that, what we call like the pre-hypertension range or the elevated range. That would be if that top number was between the number 120 up to 129. And again, that bottom number usually just hangs out still below 80. Okay. So once you start seeing blood pressures like, let's say 127 over 85 or something, that's still considered pre-hypertension and in an elevated range, which is not considered normal. So then once you hit above that 130 mark for that systolic top number there, you're definitely in that stage 1 high blood pressure range. So 130 to 139, that bottom number is anywhere from 80 to 89. And so patients will come in and they could have a one-off. They could say their blood pressure is 134 over 82 or something. That is considered stage 1 hypertension in that range there. Stage 2 hypertension goes with once you hit the top number of 140 or higher or 90 on the bottom number or higher. Then we go into some different stages where we talk about hypertensive crisis and, there's something called hypertensive emergency. Some really kind of more worrisome things. But once we get really concerned, we're talking about numbers that are, higher than 180 for the top number, higher than 120 for the bottom number. I had a patient the other day come in with a history of hypertension, and she came in and her blood pressure was, what I could measure was at least 240 over 115. Wow. And that's with me doing it manually. And if anyone's ever taken a manual blood pressure, they know that, when I say it's at least that, I mean, I am pumping that cuff up as hard and as high as it will possibly go without harming this person's arm and much as they can tolerate it. And that's the number that I'm getting at. So we can get some pretty high blood pressure readings. And especially in those higher numbers, they have to be controlled when bringing it down. It's not something you just say, oh, let's take a pill and pop and bring it back down. Sometimes they have to go into the hospital and be on drips to slowly bring this down so we actually don't cause them to have a stroke.
Yeah, because your body's gotten kind of used to that a little bit, try to compensate at least.
Right.
And so if you take away that compensation all of a sudden, then it may not know what to do.
Absolutely. Those kidneys need that perfusion as well. So there's a lot of factors that go into this. It's not just here's my number and where it's at. But I think that the other thing we have to mention here is that you can't diagnose high blood pressure off of just one blood pressure reading, right? So you have to have at least 3 different readings that are in that either elevated or that stage 1, stage 2 hypertension category on at least 2 separate occasions. So patients may come into my clinic and let's say they have a blood pressure that day they see me, never had a history of hypertension in the past, and it's 142 over, 85. That would be considered what we say with our range, a stage 2 high blood pressure reading. And we repeat it twice in the clinic, right? Okay, just double check. Maybe we're a little scared at first when you walked in, that whole white coat hypertension concern. And we recheck it again. It's 143 over 87. So definitely meets that stage 2 hypertension reading, but we can't label them with having high blood pressure until we recheck this at another setting. So maybe they say, oh, well, I've checked it at home and it was like that. Okay, perfect. There's a diagnosis. Or let's say, well, yeah, I was at the dentist last week and it was also like that.
Yeah.
Okay, there's your diagnosis. If not, oftentimes we'll have them come back again, maybe in a couple weeks, or have them do a home blood pressure log reading and send those in so that we can confirm, is this an isolated incident? Maybe they had the COVID or flu, right? And they were feeling sick and under the weather and took a bunch of decongestants. We really have to make sure that we understand that this is a diagnosis that accounts for more than just one sitting and one blood pressure reading.
Yeah, absolutely. And are there different types of high blood pressure or hypertensions, or is all of it the same?
Yeah. So sometimes if you Google, you're going to come up with a couple different, very specific medical terms. For our medical listeners, they do have to know the difference between these things. For our non-medical listeners, you may not be as concerned which type of hypertension you have, but it makes a difference to your doctor when they're trying to figure out why you have it. So primary essential hypertension is the most common type. There's really no true identifiable cause. People will be like, well, what's causing this? And we can say, well, there are some lifestyle things that could obviously be causing it. Smoking, obesity, there's just a range of things that could affect it and make it more common to have hypertension, but it's not something like when we talk about secondary hypertension that is usually really good and reversible. This usually is developed gradually over time as well. This is the most common. This is the one that you hear about. Okay, well, mom had high blood pressure, brother had high blood pressure, I may end up having it too. Secondary hypertension is usually caused by an underlying condition. That's why it's called secondary. It's secondary to something else. Sometimes it can be from a chronic kidney disease, certain hormonal disorders, certain medications. One of my favorite ones is sleep apnea. Untreated sleep apnea definitely causes uncontrolled blood pressure and not just causes hypertension, but usually one that's really hard to control where you're on multiple medications as well. This can sometimes appear suddenly and lead to higher blood pressure than primary hypertension, although we see both of them with high readings either way, and both need to be treated. With secondary hypertension, yes, you can reverse maybe some of these other underlying conditions, like let's say sleep apnea, we get them treated with a CPAP. That takes some time. And your body really needs treatment for the high blood pressure immediately. It's not something we can just say, oh, well, we'll wait and see how it goes after I've treated the sleep apnea. Not usually can we do that. If you're coming in with a blood pressure of 160 over 95, we need to go ahead and treat that due to your risk of, cardiovascular events like stroke and heart attack.
Yeah. And maybe come off medications later.
Right. And and that is my goal. I would love to, put you on a little sprinkle dose of medication, see if we can get this controlled just to help those kidneys out, help that heart out, prevent any immediate issue. But then you work on things. Let's say you work on your diabetes, your weight loss, you treat your hypertension. I love taking people off of blood pressure medicine. And that's one of the common things people will say too, is that if I go on blood pressure medicine, I'll have to be on it forever.
Yeah.
Well, that's not necessarily true. It's kind of like a scale, right? If we do something here and you want, a different outcome, you've got to balance the scale. You've got to change something on the other side. I can't just say, okay, I'm stopping your blood pressure medicine. Your blood pressure will be perfect now if you haven't done something else to account for that, to bring that pressure down.
And I also want to put that note in here now that just because you have controlled blood pressure, if your doctor asks you if you have blood pressure problems, you still have blood pressure problems. I don't know how many times I've been like, do you have high blood pressure? Be like, no. Well, because I take medication. Do you have controlled high blood pressure, which is important for your doctor to know?
Yeah.
So just putting that out there because I see that one quite a bit.
Yeah, you get a gold star for having controlled high
Yeah.
blood pressure. Great. But you still have hypertension. So when they come in and they say, no, I have no medical conditions, and you ask any history of high blood pressure, diabetes, you go through the list and they say, nope, nope, nope. And then I'm like, okay, why are we
you on this
taking
medicine?
losartan?
Yeah.
And they're like, oh, it was for my blood pressure. It used to be high. I'm like, well, you're correct. The
Yeah.
blood pressure medicine is why it's not high anymore.
Right, exactly. And we know you mentioned some of these that some high blood pressure can be avoided or improved by modifying risk factors for developing it. And again, you've mentioned some of these, but what are some of those common risk factors?
Yeah, so there's some risk factors that we can change, right? Like you said, they call them modifiable risk factors, and some that we can't, and those are non-modifiable risk factors. Some of the risk factors we can change are things like an unhealthy diet, excess salt or sodium in the diet. I always want to put a caveat here that a lot of patients, when I talk to them about sodium in their diet, they just think of adding salt, like table salt of foods. We're not just talking about that. Yes, if you are one of those people that just loves putting tons of salt on your food, yeah, we can modify that. But also talking about what I call sneaky sodium. And that's things that you'd maybe have no idea that there's an excess amount of salt in it. Things like canned foods, things about like some of the microwavable foods, things that actually have a lot of preservatives that use salt. Salt's a great preservative.
Lunch meat, that's a
lunch
big one
meat,
too.
yes.
Yeah.
Beer, there's a lot of different ones that have a lot of sodium. And so you really got to look for that sneaky sodium. But also an unhealthy diet with low in potassium, lots of processed foods. There's a lot of things that can actually lead to having high blood pressure that we could maybe modify. My favorite one is lack of physical activity. A lot of people will come in and they'll say, well, I'm exercising all the time and I'm just not losing weight. I want to say, okay, well, weight loss is 80% diet and then adding that 20% in exercise. You need both. But the huge perk is that exercise brings down your blood pressure. It's a huge modifiable risk factor. Smoking definitely is one that we can look at. Alcohol consumption. Alcohol increases your blood pressure as well. So making sure that you are really being aware of the recommendations for what would be considered moderate use of alcohol and not going overboard with that, or pulling back if you do have risk factors like high blood pressure. Being overweight, having obesity definitely increases that risk for high blood pressure. Chronic stress, although it's really kind of debatable on this one.
Yeah.
Definitely, right?
Yeah.
Patients come in all the time and they're like, I've just been under a lot of stress lately. And they may have. One lady was just telling me the other day, her husband's been sick. She's been doing a house remodel. That is a lot of stress. I've been there. We've both been there. We've done that. It's stress. But I tell them, unless that stress is going to go away completely tomorrow or when they walk out of my clinic, that blood pressure that's elevated from, let's just say it's the stress, and they could have other risk factors too. But if they're not going to change that tomorrow or today when they walk out of the clinic, they have to do something about it to control that blood pressure. Those little kidneys and that heart in the body, they have absolutely no clue that you're stressed out because, your house remodel is taking too long. They just know that they're receiving this hit all the time from having high blood pressure. And so it needs to be treated. And again, like we talked about before, if you can modify this risk factor, and we can bring it down, then guess what? Your blood pressure medicine is probably going to be too strong. And so we can cut it down the dose, keep cutting it down until you don't need to be on it anymore.
Yeah. And life stressors will always be there. So like you said, the question is, if that's how your body is responding, then we need to treat it another way.
Absolutely. And then some of those risk factors we can't modify include things like, your genetics or family history. It's real. Aging, risk actually for hypertension increases with age. Gender, men are more likely to develop it at a younger age, and a woman's risk actually increases after menopause. Race has an effect as well. African Americans have a higher risk. Black people in general have one of the highest rates of hypertension in actually the world. So this is something to be aware of. It's not a bad thing. It's just something that we need to think about whenever we see a patient and have those conversations.
Absolutely. We've always been taught that hypertension is often called the silent killer because, as we mentioned, you usually have no symptoms until you sometimes begin having complications. However, in some cases, you can have symptoms, and this could include headaches, dizziness, some blurred vision. Some people could have chest pain or shortness of breath. What are some of the complications of high blood pressure that we see if not treated?
So we see a lot of complications of high blood pressure. Complications can include things like heart disease, the kind of layman's terms for saying things like heart attack, heart failure, and enlarged heart. One of the things we often talk about that enlarged heart is called cardiomyopathy. It's just too much pressure of too much time in that heart. It's just having to work extra hard for this. Stroke, we can have that's either a blocked or a burst blood vessel in the brain. I talked to a patient yesterday, and she had a subarachnoid hemorrhage of her brain, which means that there was a bleed deep in the brain. And no one ever told her that that's called a stroke. as well. She's like, that was the first time someone ever said the word stroke to me, because I was trying to correlate her high blood pressure causing this and then relating it to stroke. And so, we use all these medical terms, but it really all goes back to the same thing, right? We're trying to talk about controlling the pressure and decreasing the risk for these really scary complications. Kidney damage. Okay, that's the one I always talk about. You keep hearing me say things about the fragile little kidneys. They are fragile. And for all our nephrologists out there, they probably really love us talking about high blood pressure, because it is one of the leading causes of people being on dialysis with kidney failure. And what I counsel my patients on, if you don't take it seriously, it can really damage those kidneys, cause long-term effects, end up on dialysis. And a lot of times the life expectancy once you start dialysis is about 5 years.
Yeah.
That's pretty eye-opening for people.
Absolutely.
Eye damage, hypertensive retinopathy. Your little retina is also really, really sensitive. Think about those tiny, tiny little fragile blood vessels. And then even cognition issues, dementia. There's things called like vascular dementia that happen from the effects on blood pressure in the brain, some memory loss. And then I always want to throw this one out there as well, because definitely my men start to think about this, but it can have effects on things like erectile dysfunction as well. And so combining all these things, somebody will hear all these things, this whole list of potential complications, and one will speak to them. For me personally, if I read this list, it would be the dialysis thing. That would be on my page, be like, no, keep me away from that. But somebody else might say, you know what, it's that cognitive concern or it's the stroke or the eye damage. And sometimes for some of the men, they'll be like, I don't care about stroke. I don't care about any of that, but I care about my erectile dysfunction. So we've really got to find what speaks to a person when we talk to a patient about what they're most concerned about.
Yeah. And if someone does come to see you in your office, say they're establishing care or they're transferring care, when do you usually recommend starting screening for high blood pressure?
It's recommended for individuals age 40 and older, or those with any risk factors such as someone with certain medical diagnoses, that they should get their blood pressure checked at least annually. Now, that's a recommendation out there, but every time you go into the doctor's office, even if you're going in for, a cold, you're going to get your blood pressure checked. So we, in this day and age, have so many opportunities to get your blood pressure checked that it should be very easy to know, do I have high blood pressure? What does it look like? I mean, the dentist checks it for, that's a big deal. So yes, at minimum 40 and older, you need to be checking it once a year. But I think that you should be seeing your primary care doctor every single year, once a year, and have it checked.
Okay. And so once they get the screening, how would you diagnose them?
So that's kind of what we talked about before, right? You have to have that very specific numbers that we're looking at, as well as checking it on those 2 different occasions. And then once it's diagnosed, we really sometimes run some additional tests to look for any complications of hypertension. Sometimes we will tell you to go ahead and get a home blood pressure cuff so that you can monitor it, especially if those patients who are like, hey, my blood pressure is beautiful at home. This is just white coat hypertension. That's great, but I make you prove it, right? And I will tell you, a good 90 to 95% of the time when that patient gets the blood pressure cuff and takes it home and starts checking it, their blood pressure is elevated at home. Maybe not as bad as in the clinic, but it is elevated. So you need a blood pressure cuff, and oftentimes we'll draw several labs that are looking for things as well. If you have risk factors for something like obstructive sleep apnea, we may also order some testing for that as well.
Yeah. And I doubt anybody listening has never seen this, but just in case on the off chance you haven't, basically the blood pressure cuff is usually when they put that little thing, they slide it over your arm, make you uncross your legs, sit, and it squeezes sometimes really hard and then relaxes to get those 2 numbers, that top number and that bottom number. So just if you hadn't happened to see a blood pressure cuff or monitor yet by some chance, that's what it would look like. So if you go to the doctor and they do that, that's what they're testing for.
Absolutely. And, the other thing is that we don't check blood pressure in the clinic, honestly, probably the best way every time. You're running in, let's say you're running late for your appointment. You ran up the stairs to my office. It was on the 2nd floor. So kudos to you for taking the stairs, but you run up the stairs and you go check in, and then your insurance issues are causing troubles up there. So you're getting frustrated about that. Then they grab you because they're running late into the exam room. You sit down, your legs might be crossed. You're talking the whole time because you're chatting up my nurse who's just so friendly. And then you get a blood pressure reading. That's not the way we should do it. So there are some specific guidelines on how to check that blood pressure the right way. And so you can look those things up. You can ask your doctor what's the best way to check it, because there are some tips and tricks that we can give patients for that as well.
Yeah, I always felt like that when I was pregnant. I was like super pregnant, rushing in, trying to get to the 2nd floor, and then they immediately want to take my blood pressure, and I'm still out of breath. But all right, so we've diagnosed them now, and we checked for complications. what are going to be some of the initial or recommended treatments or management we're going to recommend?
So it really depends on what level you're at as well. So if
Mhm.
you come in like that one patient I was talking about with the 240 over, 115, we got problems. We're not going to just say, oh, goodbye, go home and, do some things there. That's a different situation. Also different if you came in and let's say your blood pressure was, 155 over 95. I probably am not going to let you leave that day without a little bit of a sprinkle of some kind of medication. But if you come in and let's say you're in that stage 1 high blood pressure range and you are saying you are motivated, you are ready to make some changes, then let's do it. Let's start making some changes. Some lifestyle changes that could start with a healthy diet. The favorite one to recommend is called the DASH diet, DASH, like you're dashing, in a race. It's rich in fruits, vegetables, whole grains, and low in sodium. Very Mediterranean diet-esque. It's wonderful. It's also great because it prevents diabetes and helps with weight loss. So you get the 3-for-1 deal on that one. And then getting regular exercise. When we say that, we're really recommending at least 150 minutes per week of moderate intensity exercise. What I tell my patients is you need to get your heart rate up. If you are not cursing my name while you were like on a treadmill or something and saying, darn you, Dr. Gray, you made me go break a sweat and get uncomfortable, then you're probably not doing quite enough. Just, walking around at work is not enough.
Yep.
Losing excess weight can significantly reduce blood pressure, reducing salt intake, like we were talking about, that sneaky sodium is really understanding where that is in your diet. You can use some apps that help track those things that you can really understand, okay, wait, ow, wow, that, that drink that I like to order from what is that one that everyone always like? The Dutch Bros. I feel like I see that a lot. Might have, you're like, well, I knew it has sugar, but it also had a lot of sodium in it too. So limiting to less than 2,300 milligrams in a day. Ideally, you want 1,500 milligrams or less for people with high blood pressure. Limiting alcohol, stop smoking, and ask your doctor for some help with stopping smoking. And then, of course, stress management. Yes, you can work on things like meditation, yoga, deep breathing techniques. And then medications, which include several different kinds. We usually start with something like an ACE inhibitor medication or an ARB. These are very common medications like lisinopril, losartan, valsartan. They work in very specific ways on the kidneys and relaxing these blood vessels. It's really pretty neat, actually. Then sometimes we'll go to a diuretic that helps remove some of the electrolytes that can affect the blood pressure as well. These diuretics often are like hydrochlorothiazide is a very common one that we use. We then maybe go to a calcium channel blocker like amlodipine. These ones work in a different way than the others as well. And then a beta blocker usually is kind of the last one, reducing heart rate and workload on that heart. We use these in different ways. So if you say, okay, my husband or my friend or my dad is on a different blood pressure medicine than I am, it may be because we're targeting different things. So if you're also a diabetic with high blood pressure, we're going to usually start with an ACE inhibitor or an ARB because these medications are protective on the kidneys. If you have certain other conditions, we actually may add in that beta blocker more quickly, especially things with some cardiovascular heart disease issues or heart failure issues.
Okay, so we've covered how hypertension or high blood pressure is defined, the risk factors for developing it, the complications that can occur, some possible symptoms you may have, although remember you could have no symptoms at all that are obvious, how we diagnose it, and how it's treated. Don't forget to talk to your doctor about screening for high blood pressure if you haven't already.
Absolutely.
All right, now we're going to pivot and talk about the medical news that had Dr. Sanjay Gupta from CNN showing up at our local hospital.
Oh, and they had RFK calling, the health department last night as well.
Nice.
So I think we need to date this. So we are recording this on February 27th, 2025. Every single day and even like every half day, something's changing. So if somebody comes back later, is like, your numbers are not, to date.
Yeah.
Just FYI, this is the date that we're recording this episode.
Yeah, we can't help it if it increased, as we're talking right now.
As we're talking, it most likely will.
Yeah, and I know we briefly mentioned measles in a previous episode, but at the time we did not know or had any idea the extent the current measles outbreak would expand.
Yeah.
I mean, by the time this episode releases, I'm sure the numbers will be even higher, but we've seen now over 100 confirmed cases thus far.
Yeah, it's about 124 as of yesterday, with about 20 currently still hospitalized and 1 death yesterday as well.
Yeah. And Jess and I, of course, are living in the epicenter of the outbreak, which is now spread across parts of Texas and New Mexico, and I think maybe even beyond potentially based on what I saw in the news.
So we're seeing the largest measles outbreak in about 30 years. The outbreak is primarily concentrated in the region that we live in here, which is called the South Plains region in West Texas. We have, like I said, about 20 hospitalized right now. At the moment, those that have been affected out of that 124, 5 of the affected were vaccinated, we think. And so we can talk about that at the moment as well. There's a little caveat on that. And then the majority are unvaccinated or have unknown vaccination statuses, which we generally are assuming is unvaccinated. It's also concentrated heavily in some certain communities that have a very high vaccination opt-out rate as well.
Yeah, absolutely. And I know that was one of our listener questions. So we're going to touch on that at the end of giving some information. And just in case you don't know what it is, measles is a highly contagious viral disease that's transmitted through airborne droplets. And so it's primarily respiratory in nature. And fascinatingly, the measles virus can survive in the air for up to 2 hours after somebody, coughs it in.
Right.
And symptoms don't typically start appearing until 7 to 14 days after that exposure, which is why the likelihood of spread is so high, because you can go a lot of places in 1 to 2 weeks without even realizing that you could potentially be sick.
And that's the funny thing, our breaking news from yesterday is there are now 2 exposure sites. And this is probably going to get worse by the time this episode airs. But as of yesterday, in the last 24 hours, they had just announced that if you had been to a certain Target and a certain Walmart that were very, very popular,
very busy
on February 19th and February 20th, you are potentially at risk if you are unvaccinated or immunocompromised as well would be some of those cases too. But it's kind of crazy. Yeah, it lives in the air for 2 hours. It shuts down. Like if somebody were to walk into my lobby and have measles, it would shut down our entire clinic. We'd have to send every single person home, isolate the clinic for at least 2 hours, and then start doing contact tracing to anyone who might have been in that area near where that person would be.
That's crazy. And if you do start having symptoms, there's kind of 2 phases that we usually see. So they call it the early symptoms or the prodromal phase, and that lasts like 2 to 4 days. And you can start seeing high fevers, like above 104 degrees Fahrenheit or 40 Celsius, if it happens to be somebody listening who doesn't know Fahrenheit. You can start getting a cough, runny nose, and that conjunctivitis or red watery eyes. You can also start getting some tiny spots inside the mouth as well. And then they start getting the rash phase. And that's usually a few days, 3 to 5 after the initial symptoms start. And it's kind of a red, blotchy appearing rash. It can kind of start on the face, usually spreads downward on the body, and usually lasts about a week before it starts fading.
And that's the thing that we want to really talk about is that there is a pretty big myth out there saying that measles is just a rash. I think people kind of forget because we have had a lot less of some of these previously common childhood illnesses. Measles and chickenpox are not the same thing.
No.
Like, people are like, well, yeah, my mom had measles parties, and we're talking about people that are like my age. And I'm like, no, that was chickenpox.
Yeah.
You're talking about different things. Fortunately, the mortality and the death rate is low-ish. The problem is that we weren't seeing this very much. So that's why we can say it's low. Right now, the mortality rate for children who have measles is 1 to 3 out of every 1,000 children infected. That's actually a very, very high rate when we're talking about comparatively to certain other childhood illnesses. And we can lead to very severe complications, especially in young children, pregnant women, and those with a weakened immune system. So the child that just passed away this week was an unvaccinated elementary age child. And we don't know exactly if they had any other medical illnesses or things, but this is the reason why we have the MMR vaccine, is to try to save these little children or even help provide some coverage and immunity to kiddos that can't get the vaccine because they're too young. But again, this whole like measles is a rash thing is not true. It can cause pneumonia, which is the leading cause of death in these measles cases. Pneumonia leads to respiratory failure, which is very, very scary, especially when you're thinking about little kiddos. We get scared enough for things like RSV, and then pneumonia has been on the rise lately in kids anyways, just in general. And so it's scary to see this link. And then encephalitis, which is a brain swelling that can cause brain damage. It can cause deafness, blindness. There's all sorts of things that are related to that. But I had somebody like fight back on me, and they're like, well, that's as rare as falling off your bicycle. And I was like, what kind of, don't people fall off their bicycle all the time? I felt like that was a really weird comparison. But it is not as common. Not everyone's going to have it. But when you look at these cases and the numbers that have this, it's really, really high. 1 in 20 kids who get it will end up with pneumonia. If you look at the number of people hospitalized, the number of people affected, the statistics are not in our favor saying that this is just a rash situation.
Right.
And then the really scary stuff is that you can develop certain conditions years later after having measles. So all this whole, anti-vax thing saying that, no, you should just get natural immunity from measles by having it is really scary because, okay, let's say your kid gets it. They do fine. You're in the case where you're not worried about any pneumonia. But years and years later, you could actually get a fatal brain disease, basically, called subacute sclerosing panencephalitis. It's a mouthful there, right? But in most layman terms, it's an infection of the brain that presents with causing seizures, cognitive decline, dementia, death. There's really a bunch of scary things that can actually happen with this.
Yeah. And I think a lot of people are kind of confused on, especially the pneumonia part of it and how that can occur. But just in general, remember that measles really shuts down your immune system pretty severely. So it leaves you exposed and at risk for other types of infections as well.
Absolutely.
So it's not even just the virus itself. It's what other things that you usually fight off really well when your immune system's strong and you're healthy, that all of a sudden your body just can't fight off the same way. So that's where that really gets concerning, is what other things you could catch. And like Jess mentioned, vaccination remains the most effective preventative measure that we have. The MMR vaccine, which protects against measles, mumps, and rubella, is approximately 97% effective after 2 doses, which is fantastic.
Yeah. You
usually get your first dose at about 12 to 15 months of age, and usually that second dose at about 4 to 6 years. Although, and we'll talk about this more later, if a child has an exposure and it's deemed to be in the criteria, you can get another dose early, and usually you want it to be at least 12 months since the very first dose that you've gotten. And it's important to remember that even if you contract the disease after being vaccinated makes you have a milder course usually and less risk of complications.
Absolutely. So one of the things we talked about were those 5 so far out of that 124 that we think had been vaccinated. 4 out of those 5, we think were at least people who were about 45 years or older and had very minimal symptoms. None of them were hospitalized whatsoever. The last one was somebody that most likely said they were vaccinated, but we're not necessarily pulling vaccine records for every single person. And so there may be a questionable history about that. Or there's also some people that we have talked about that they are not aware that when you get your vaccine, you actually take about 2 weeks to get immunity. So there was a patient, actually, we swabbed just this week in my clinic for measles, and we were concerned because they actually got their vaccine, but they had an exposure to one of the exposure sites a couple days before receiving their vaccine. And they hadn't had the preventative, they were in that window of having that immunity built up yet. So there are a couple things there. And one thing I just want to touch base on this one, because I'm getting so much flack on it on social media right now, is the vitamin A thing for prevention. So vitamin A does not prevent measles. The only prevention measure that we have that's actually been proven is the MMR vaccine. Vitamin A can be used to treat measles in hospitalized individuals. This is also not something we recommend you just routinely do at home. There are a lot of people, coming at me on the social media these days that are saying things about, you can just mega dose it at home. I would highly, highly, highly recommend against that.
Yep.
As a liver specialist in the room right here, she'll tell you that you can have a vitamin A toxicity, which is very scary. You can have a lot of different vitamins that can harm things like your liver, cause blindness, all sorts of crazy stuff. So yes, vitamin A has a role in treating measles. It is in the hospitalized patient at very specific safe doses for this patient in short cases. So this is not something to be doing at home. And so in general, just saying load your kids up on vitamin A to prevent from getting measles is not accurate.
Yeah. And I actually did see an article just last week that came out in one of our journals that the increase of liver damage with supplements is on the rise as well. So, and sense. I don't know if that's necessarily correlating with what people are trying to do at home, but we are seeing more of it as people try to self-dose some of these could be dangerous supplements at home as well.
Yeah, absolutely. And then what's sad is that measles was declared eliminated in the United States in 2000, but outbreaks have been increasing year over year due to declining vaccination rates. And one of the things that I will say, I hear you people when you're saying stuff on social media, you have no confidence in us and apparently mainstream doctors. I get it. And we want to earn that confidence, right? We want to bring you information like we're doing now today, where we're telling you we are not paid by Big Pharma.
Yeah, absolutely. That seems to be a big misconception.
Oh, man. Someone like commented and said that my medical school was all paid for by Big Pharma. And I was like, man, I am a first generation college student who paid for my college and med school out of student loans. Big Pharma, do you want to come back and pay me? Because that
would be nice.
Loans, right?
That would be nice.
And then someone else told me, a recent really good friend told me that one of the other common ones that are being said is that we get paid every time we give a vaccine in clinic. And that's why we are vaccine pushers. I do not get paid to give a single vaccine. And also the other thing is it's really hard for us to get vaccines covered by insurance sometimes. And so sometimes your doctors like me go at a loss. Like we actually have to lose money in order to give the vaccines. So it's the exact opposite of what's out there. Just had to throw that one out there.
Absolutely. Yeah.
But yeah, it was completely gone, guys. The virus spreads extremely easily. Even a single case can lead to large outbreaks in unvaccinated communities like we're seeing. The county thought to be the epicenter of this current outbreak has roughly a 14% exemption rate for school children for vaccines, with one school district being as high as 48%, meaning 48% of those kiddos were not vaccinated by choice.
Yeah, that's scary. And that's, why we're seeing outbreaks like we have now. And we mentioned this before, but a person is contagious for about 4 days before the rash appears to 4 days after. So what are the current recommendations for exposure if you are concerned you might be getting symptoms? So people with measles should stay home from work or school during that period. During an outbreak, people with documented immunity from vaccination or previous measles infection should still isolate themselves from anyone with measles to protect those without immunity and control the outbreak. In Texas, I think their guidelines are that schools and childcare settings exclude unimmunized children for up to 21 days after the last date that an unimmunized child was exposed to a measles case. So they're just that concerned about it spreading that, they really, really emphasize, staying home.
Right. So how do we test for it? This is a fun thing I, recently did and got to learn about because there's a lot of fun paperwork that goes with it. The test for measles include a throat and it's like a nasopharyngeal swab is what we call it. So we kind of do some swab in all the areas with a special swab that gets sent to a specific lab for testing. It's not something you can go to like any lab test now or a Quest and just a request to get done. Those places might be able to draw like an IgG titer for measles, which means if you have immunity, but that wouldn't be something that would be related to like, do I have measles? So don't go try looking for testing yourself in that way.
Yeah. And of course, if you get to the point of needing treatment, you're going to have healthcare providers who will guide you on this. And it is kind of supporting you through a lot of these things. Like we mentioned, if you're having trouble breathing or having respiratory symptoms, we support you through that with, artificial breathing or supplemental oxygen, et cetera. But there is actually an immunoglobulin, which is an antibody that binds a part of the virus to help neutralize it. That can be administered within 6 days of that initial measles exposure and may provide some protection against measles or at least modify the course of disease among those people that are very susceptible. And it's given sometimes a shot in the arm or sometimes in the vein or intravenously. And this is actually the only option for what we call post-exposure prophylaxis for populations that cannot receive the MMR vaccine. So like just mentioned, those infants that are less than 6 months of age, those that are severely immunocompromised, and pregnant women.
And I think that's one of the questions too that we were trying to address some of these were sent in over social media was that people will say, well, why can't my infant under the age of 12 have the MMR vaccine? And it's really not necessarily couldn't have it or it's dangerous. That's a common thing that's online right now. It's not dangerous. 6 months and up can receive it in specific situations like this outbreak right now. And even 10 months and up had been previous to this outbreak been able to receive it if they were traveling internationally. It's not about safety, it's about efficacy.
Yeah.
So it's about that the baby's immune system is not mature enough to be able to remember this immunity. And so you would just have to repeat those doses later. So it is very safe. I can say right now that my infant actually got his MMR vaccine early, which I was thrilled about because I am concerned about this outbreak and he is under the age of 12 months. And I have a very good colleague who she was traveling internationally with her baby and her baby's 10 months and was going to be going on a cruise during this outbreak. And so they were able to get it as well. So it's not about safety, it's about efficacy.
Yeah. And I think one of the things too that people may not know as well, when they talk about babies under 6 months of age, is that if you as a mom are vaccinated, you actually pass some of that protection to your
Yes.
baby. So that's the good part about it, is that they still have some protection from you, thankfully, as
Yep. The
mom.
maternal antibodies
Yeah.
are supposed to be, they think, lasting about 6 months. So
Mhm.
if we think about that, these babies we shouldn't have had to worry about them in the
Right.
appropriate setting, right? Maternal antibodies should cover hopefully to 6 months, and then they only had a little tiny window back in the good days,
Yeah,
right?
6 months.
Where they wouldn't have had to be worried, and everybody else was vaccinated and the rates were gone and we had eliminated it. Well, now that this rates have gone back up and measles is back, now we have to worry about these babies that have not a lot of choice often for getting these vaccinations.
Yeah, and one of the questions that I did see too is that people were saying, well, why can't just everybody get immunoglobulin? And really, you kind of want to limit that and prioritize it for people who are exposed in settings with intense, prolonged, close contact to somebody who's infected. And for those that are really high risk for severe disease, severely immunocompromised, again, is like we talked about. And really, a lot of that has to do with how much we have available as well. It's only something we can get so quickly. So if you use it up on people that are not necessarily high risk, then you don't have it on for the people who are. The good thing about it, the effectiveness rate that I was kind of able to find for it was roughly about 83%. So I did see some variation on that, but it can be effective if we need it.
And one thing I think is nice about the measles outbreak, if I can say there's something nice about it, is that measles has been around for so long that this is not new. It's not like COVID world where we're just making stuff up, right? Which we were, I'll fully admit, sometimes we were just making stuff up. Not in a bad way, but we're doing it the best of our knowledge at the moment. And everybody's, was freaking out about the COVID vaccine. Well, we have treatments, we have historical data, going back so many years for this, that guys, we know how to treat this. And sadly, even if we know how to treat it, there's going to be some scary cases, like the case of the child that died this week. We did everything possible. One thing that, again, people keep saying is that this whole vitamin A thing, yes, we can use vitamin A in these hospitalized patients. Yes, I was not this child's doctor, but I can guarantee they were given everything, including vitamin A, and that did not solve the problem, right? So let's not, sugarcoat this and act like we need measles parties and just, we'll just amp up the vitamin A if somebody gets it. We don't know how long this outbreak will last. We have some historical data to go on actually based on some other recent outbreaks. In 2014, there was an outbreak in an Amish community in Ohio. During that outbreak, a total of 383 confirmed measles cases were reported over roughly about 120 days or 4 months until it finally just started fizzling out. That was, though, a review of all of the measles that I really hope brought everyone up to date, at least to today, again, February 27th, because I'm sure as of this afternoon or tomorrow, and especially by the time this airs, there's going to be some new health updates. But keep us in your mind, with this current outbreak we're seeing in the Texas healthcare community. Your healthcare workers, we love you guys. I promise. We are not big pharma. We love you guys. We do this out of, the goodness of our hearts, like talking about these things and educating. It is not because we get some kind of kickback. We truly genuinely care about all the patients we see. We care about our kids as well, because believe it or not, we're moms as well. And we make these decisions about vaccinating our own children too.
Absolutely. And just also really tune in and pay attention to what your local public health is telling you, because we do have such variation location to location. So what we were talking about here and for our community may not be the same thing your provider is telling you a little bit of ways away, because they have different information to go on.
Absolutely.
All right, so we are going to answer some of the questions that we received off of social media. I think the one that we're going to answer first was a really great one that we had as well, that said, they had heard if you were born at a certain time that maybe you weren't protected because of your measles vaccination because they were doing a different schedule. Jess, can you answer that one for us?
Yeah, so really there's a lot of stuff everyone keeps talking about, when were you born and things like that. So first things first, if you were born before 1957, you do not have to get an MMR booster, and most likely you never received an MMR vaccine. We actually assume you had natural immunity due to how prevalent measles was back then. So it is not common that you would need to go get any additional booster or things like that currently. The rest of them, starting in 1960, when we really had the MMR vaccinations and everyone was getting them, those ones we assume that hopefully your vaccine status. At least in Texas, it is required that you have your MMR vaccine to enroll in public school, and you would have to opt out in order to attend public school without it. So if you did not opt out of your vaccines to attend public school, then you received the 2 doses. And again, having those 2 doses, at this point in time, all the health departments are saying you don't need to go check titers on anybody for that. That is good enough coverage.
Yeah. And one of the interesting things I did see on the CDC website, which I actually wasn't really aware of until I was looking into this question, is that a very small group of people who may be listening, if you were born between 1963 and 68, are what that small group that may, if you don't have your vaccine records, may need to have titers checked, because at that time they were using an inactivated form of the virus to do vaccines, which they found ultimately was not effective. And that only really applies to about 600,000 people in the US that received that vaccine in that short period of time. But if that very niche period applies to you and you don't have your vaccine record to see what vaccine you received, then you may need to have your titers checked.
Just go talk to your doctor.
Yeah, just ask them.
Like I said before, unlike when COVID world, we have protocols on protocols on protocols for this. It's really actually super nice to have that.
Okay. And then one of the other questions, is my vaccinated child at risk for death if they caught measles, or if their body would fight better if they were vaccinated?
So that's the whole point, right? So we are saying that our babies, when they have the measles vaccine, they should have that protection. This should help them fight off the virus or not be infected by it. That's the thing. So most of the time, again, talking about those large statistics there, all the people that are infected with measles have not had the vaccine, except for that very small proportion. And when we're talking about that small proportion, they're all really doing very, very well.
Mm-hmm.
We could do a whole other episode talking about combating this, talk about like if you get the vaccine and then it's a live virus and you're shedding and blah, blah, blah. Just know this. We can test because it is a live virus, and yes, there's a very, very small chance you could get the actual measles virus from the vaccine. We can test for that. Every single one of these cases that has been reported, it was tested, not locally, but at the state level, to confirm the strain and to confirm it was not related to a vaccination. Mm-hmm. So those 5 that have it, it was not related to an MMR vaccine. That has been confirmed by testing those strains.
Yeah, absolutely. I think that kind of answers one of the other questions we had about, like, could you transmit it if you are vaccinated? And really, it's mostly because your body neutralizes it so quickly that window, that likelihood of spreading it is much, much lower as well, because it's neutralized by those lovely antibodies that you have in your body.
And that was one of the things with COVID. We were really concerned because we thought we were, as healthcare workers, especially bringing it home to our families. Mm-hmm. We were so worried. We're like, well, if I don't have it, am I bringing it all home to my families? Right now, the nice thing is being vaccinated, you can feel pretty comfortable that you're not going to be bringing this home to your little kiddos. Yep. Still wash your hands, do all the good things anyways.
Absolutely. Right? And last one, I live a few counties away from, I'm assuming Lubbock, because that's where we are now, and have a 3.5-year-old who is kind of in that window between first and second dose of the vaccine. Should I get their second dose earlier? When does that consideration start?
So this is like my kiddo, actually. So my kiddo doesn't turn 4 for a couple of months. And so at this point in time where we are at with the outbreak and everything, and with the health department's recommendations, is that there is not needed to have an early booster. Mm-hmm. There is potentially for some changes with that. I know someone personally who their pediatrician recommended they get their early booster at 3.5 because they were traveling internationally during this outbreak. Or there may be some different recommendations if you are living in one of these true heavily outbreak communities or families with mm-hmm. that. So there's a little bit of difference there. But one thing we didn't mention before is that if you only had 1 dose of your MMR vaccine, that still has about 93% coverage for immunity there, versus then you add the 97% with the second dose. So like getting my little kiddo, his first one, my infant, I feel really good. Then I'm like, okay, 93%, mm-hmm. that's pretty darn good. Yeah. As far as immunizations go, that's good. Like this one is good. That's a coverage that we can count on.
And when your healthcare provider is considering that or making recommendations to you, this is why I said it's really important to kind of pay attention to locally, because a lot of that depends on how many cases they've had near you, the vaccination rates for the area that you live in, so that the likelihood you have what we call herd immunity, which is how we eliminated measles in the first place, because we had achieved herd immunity at mm-hmm. that time, which we don't have now, apparently. And so that's why it kind of varies person to person. So you may have 2 people who do hear different things because there's different things being considered.
Absolutely. And if you have questions and you feel like, hey, one pediatrician said this and another pediatrician said this, or family medicine that said this, there are some protocols, like I said. And so just have conversations. There may be somebody, if they're immunocompromised, that might need a little extra care, like we were talking about before, like the IV, mm-hmm. IG or IMIG, which is that immunoglobulin we're talking about. And again, that post-exposure prophylaxis stuff, like you've been exposed to it. There's a lot of things we do, and there's a whole protocol very clearly written out per the CDC to say, if you have X, Y, or Z, you kind of line it up and you can say, okay, this is when they need this. This is how and why. So yeah.
Well, thank you guys for staying along for a very thorough review of hypertension or high blood pressure, and then also kind of an update and some factual information regarding the current measles outbreak. Don't forget, if you are a listener claiming CME credit, please look in the show notes for instructions.
And for all of our listeners, thank you for tuning in. Please like, subscribe, follow us on socials, share this episode, send us some love. We need some love, guys.
Yeah.
Let us know what other topics you're interested in through our Instagram and TikTok, and stay tuned for the next episode.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the MedEdit podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Cari Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening, and tune in next time.